let's call roll.
Christy Blakely,
Yep,
Cecile Fraley,
she's on the phone. Okay,
Patricia Givens,
Present.
Simon Hambitch,
excused.
Brigida Hughes,
Present.
Jessica Coons, Amanda Moore,
Here.
Charlotte Lipolis,
Here.
Ann Nguyen,
Here.
David Potts, Donna Roberts.
Present. Okey doke, we have quorum. I'd like to introduce Kim Bimsteffer, who is our new Executive Director for Healthcare Policy and Financing. Welcome, and share some comments with us. Thank you for coming this morning.
Well, thank you very much for having me. And I think what's more important is thank you for the good work that you do. The state is important. Our citizens are important. Those going through difficult times, it's important that we stand next to them and we help them rise and help them in their circumstances. So I want to thank you for being so engaged. I want to thank you for your intellect, for your time, for your interest and passion. And my first question to you, knowing that I appreciate what you do, is how can I be of help to you in my new role? And then maybe it would help you if I introduce myself, so a little bit of my background. Why don't we do that first? But then I want you to think about that while I'm talking. How can I help you? How can I assist you in achieving your objectives? How can I help you when you leave here in your time that you've spent in this position, that you really feel like you have made the contribution that you wanted to make in this role? So just a few minutes on me. So I have about 31 years as a healthcare person myself. About 25 of that have been in an executive role, a president, a general manager, a CEO, something, position, senior vice president, like that. It's on the payer side. So I worked for 15 years for a not-for-profit payer insurance company, largely in the Northeast. Was responsible for strategy and helping the company grow and helping it cover its costs as a not-for-profit. We were in the same similar position where we weren't terribly interested in earnings at all. We're interested in providing a service. I then spent, and that I was a board-appointed officer for that company. I then spent 15 years for a Wall Street owned firm, Cigna. I built divisions for Cigna. I analyzed what the market needed for various niches, including the federal government, and I built products and services to meet the needs of individuals relative to healthcare. I oversaw divisions from service to sales and client membership support, product development, requirements, the gamut end to end. And I was also president of this market, which was Colorado, Utah, Wyoming, and New Mexico as well. So when you're president of a market, everything from unit cost and hospital payments and doctor payments and regulatory compliance and getting up an exchange and helping people in difficult times and going through tremendous recessions. And so my background is diverse. My skill set is rather robust. But at the end of the day, if every day I can feel like we're meeting the needs of the people that we serve, that we're understanding the complexities of healthcare and how to do things differently, innovative, and better than we did yesterday, that the market needs solutions. It doesn't need more of what we did yesterday. The current system we have is not sustainable. So I like change. I crave change. Because I'll say it again, the system we have in this country is not sustainable. And I think it's just come out that healthcare is the #1 expenditure now in the country. So as I look at my role in this job, I want to find a way to enhance how we deliver services, enhance the understanding of what people need, meeting them where they are in their journey, helping them rise, but doing it with a more keen eye to financial stewardship, because we have to get better at controlling cost as the highest cost of care in the world. So if you could think through in your role, help us innovate. What we did yesterday doesn't mean we have to do it the same way tomorrow. Where there's ways to change so that we achieve those things more effectively, we achieve our mission here in this organization. So if we can provide better access and better outcomes, but we do it in a way that helps everybody control costs more effectively, put your creative hat on. Don't be shy for things to do things differently. And let's talk about those things. And if you help us do that, then we're successful. Help us meet our mission, but let's bring some new ideas, shake things up a little bit, find new ways, take a leadership role, and try to solve some of the very large problems that we have in this country, starting here in Colorado. That's what I'm looking for. So with that, what do you need from me?
Questions from the board? Dr. Fraley, raise your hand if you want to say something, please.
I will do that. Thank you.
Any questions? We appreciate, and I will speak for the board first, that we appreciate the time and energy that's gone into developing this board and really cohesing this board. And I'm speaking for everyone, and a thank you that I feel we have a board that really is connected and compassionate and really listening and working hard for the betterment of Medicaid in Colorado and what we're doing. So I just appreciate what's gone before and hope we can continue to work in that vein. Dr. Lipolis?
Well, first I want to say welcome, and I appreciate
you.
your background. I think that it is helpful to know the larger market, and not just the nonprofit or the Medicaid side of things, because they intertwine. And so as goes Medicare, so goes Medicaid, so goes private insurance. And so, but in terms of patients, they're impacted by all of those in a way of confusion and not understanding the complexities that are around us. And I think even as physicians, it's hardly able to understand things most of the time. So I appreciate your interest in that and your background, frankly. Also, in terms of innovation, I am very interested in perhaps us being able to help persons who come and testify, who have specific issues, to have what sounds like an interest in being a little more innovative in what we might do to solve some of the problems that come before us physically in terms of presenting their cases. And I want to second what Christy said in terms of in the past year, there's been a lot of work put into the board development. And one of our specific requests to serve all of Colorado better, to be able to travel and have and go where the people are and be able to see their facilities.
Yep, not everything is like Denver.
Understand what's happening, particularly because we don't have non-physical testimony. So it's an issue that I have raised and will continue to raise. I'm active with telemedicine and telehealth, and it's hard for me to understand why people can't testify from a distance. If you're disabled in Cortez, how will you get your case before us? I've said it before, I'll say it until we do it. So that would be
Does seem like a strange guideline, doesn't it? We serve people who are
Strong.
disabled and then we won't help them.
strong area
testify.
of interest for me would be, please
Okay.
let us hear from everyone in the state.
Sure.
Should they have the desire to testify? There are ways to do it. I've testified for the medical board via telephone. Certainly we could figure something out. So one of my innovations I would love for you to think about.
Yeah, I think it's interesting as a doctor, you know what I'm saying. So some of the innovation, you look back and it has unintended consequences. So if you look at, so as a doctor, you know, EMRs, right? You have to get an EMR. And if you're in a rural area and you have to get EMRs, it's a lot of money. So if you have a lot of money, you have to find a big brother. Big brother becomes a hospital. And all of a sudden we lose the independence and the wealth of creativity and being able to operate, serving the needs of the community. And all of a sudden there's big brother in the city, which that relationship's created all because doctors needed to meet the needs of hitting a regulation. And that wasn't really their intent when they started. So when I ask you to be creative and to think through things, you know, I like to consider strategy like playing chess. So you turn a chessboard and you try to play 5 steps out. If I do this, what happens 5 steps out? When you're thinking of policies, think it out 5 steps. If our regulators had thought all the way out 20 steps of how would that transform the healthcare system? And was that an intended consequence or really an unintended consequence? What you do is very important work. And you have Gretchen that works with you, and she's an outstanding strategist with a wealth of background, an awesome resource. And Gretchen, thank you for your time.
Thank you.
With this committee. And I'm sure you found that to be so. But if you want to spend a little time bouncing off ideas, it's important to play chess in your roles of what is the full consequences. And I love what you just said about telemedicine. But tomorrow, the next telemedicine could be genomics and proteomics, and there's 20,000 proteins in the human genome, and people are graphing those out. And what do your proteins look like 3 years before you pass away? Oh, I noticed 1,000 other people that look like this, and this drug failed treating those people, and these drugs worked, and that diet helped, and these diets didn't. The world is progressing in technology in amazing ways. So let's open our mind to look at the ways we can use technology and rules and help play chess, consider intended consequences, unintended consequences, and let's do some good work. And if I can help you in any way, I want to be one of those folks you look back at and say, she was helpful. I'd be glad to help you in any way I can.
Any other comments, questions? If you have any question that Dr. Lipolis won't continue to ask about that, let that go away, because she will. Tenacious is a word that we use for her. And so,
Well, if it's okay with you, I'm going to stick around for just a little bit, and then I'm going to silently creep out to handle a few things that I need to handle today. But is that okay if I just take a seat over here?
Absolutely. Join us, please. And hold on to your hat, because this is the really exciting part. I'm going to do the general announcements. The date and location of the next Medical Services Board meeting. The next meeting is scheduled to be held Friday, February 9th at 2018, beginning at 9 a.m. at, new location, 8510 North Bryant Street, Westminster, Colorado, 80031 in the 11th floor conference room. That is Clinica
Yes. I don't think.
Clinica Family Health.
Oh, and it won't be in the 11th floor conference. There isn't an 11th.
I don't think they have an 11th floor.
So if you go there,
The second
good luck.
floor.
You know, you're time traveling. They do this just to make me look not great. I know this, it's fun, keeps everybody on their toes. It is the policy of this board and the department to remind everyone in attendance that this facility is private property. The capacity of the room is 105. Please do not block the doors or stand around the edges of the room. Please turn off cell phones while in the meeting as they interfere with the recording equipment. I will open an approval for the December, whoops, I see David, you're concerned about something?
This a new permanent location?
No.
This
No,
is a
we-
one time?
This is a one-time. It's part of our traveling, going outside of this building. So it's one of the facilities that provides for us. In fact, it's Ann's facility. So
Like anything else that are.
So will be lodging over there in that area then?
Yes.
Okay, and you'll let us know?
yeah, all logistics will come to you and yes. Okay, I will accept approval of the minutes. Motion, please, for December 8th.
So moved.
Dr. Lipolis, did you have a correction?
Oh, no.
Were you moving?
You can second.
Sure. I'll second.
Okay, Dave motioned, and we had a second from Dr. Lipolis. All in favor?
Aye.
Opposed?
Aye.
Thank you, Dr. Fraley. I forgot about you. You didn't have your hand up.
She opposed her for.
I won't forget now after that. So, all in favor? Any opposed? Abstain? So passes. Thank you very much, folks. Let's go to rules and the final adoption for document 01. Chandra, you can go ahead and start up here. Document 1, MSB 17-10-5-A, the revision to the Medical Assistance Special Financing Division Rule. So we will listen. Good morning. Welcome. Happy New Year. All those good things.
Thank you. You too. So this rule should have actually been on consent, but we had, from what you had approved and passed last time, we had a couple of just minor changes that we heard from some stakeholders. So all of them are going to be on page 27 of your document. Oh,
Everybody has a document in front of them, as there was an error in the copay cost.
Yes.
Okay, so everybody has the document that we should be looking at in front of us. Dr. Fraley has one as well? All right.
Yes.
All right, good. Thank you. Go
Okay.
ahead. Sorry about that
Not a
interruption.
problem. So on page 27, under the program payment, it's listed as 67. That should be listed as 77. And that's on D5511. And then under the co-payment, it was listed as 20 and it should be listed as 10. And it's going to be the exact same change for D5512. And then the other minor change is in the program guidelines. It had stated repair broken completed denture, and it should just be complete.
Oh.
So that has been changed. So those are the only changes.
All right. So any questions?
So I admit I was fairly slow. So I got the change that said, Brigida Hughes, please.
Thank you.
77. What were the other two changes?
The other two changes were under the max copay. It was listed as 20 and it should have only been 10. And that would have been for D5512 also.
We don't have D5512.
Yeah,
Oh, yeah, we do.
Yeah, just below that.
Got it. Thank you.
You bet.
And did you want to hear where the completed
Yes.
correction was? What page?
Actually, that's page 27 too. That's going to be for both DD 5511 and 5512. It was repair broken completed dentures, and it should have just been complete dentures.
Got it.
Thank you.
Okay.
welcome.
With those changes, are there any comments, questions? Dr. Fraley, do you have any questions, comments?
No.
On?
This is Anna Wynn. I went through and read this again. And I have a question about page 10 that I did not notice before.
I'm sorry, did you say page 10?
Page 10,
Okay.
In the doc,
yes, in the document that we have, it's code a D1110, and it's in the program guidelines description. It's the 1, 2, 3, 4th bullet point down. It's the descriptor that says that the code can be alternated with D4910 for the maintenance of periodontally involved individuals. So unfortunately, I read this in time and had an opportunity to speak with some of my other clinical colleagues, including someone who sits on the advisory council for the low-income senior dental benefit. So it's good that I was able to talk to some other people about this. This doesn't make a lot of clinical sense to a lot of the dental folks. The benefit is actually, the rest of the benefit is actually written really, really well. Patient has periodontal disease. You're going to bill out the 4910 code, the periodontal maintenance code, throughout the rest of their clinical care. So every 3 or 4 months for the rest of their life, they're pretty much always going to get a 4910 code. So it doesn't make a lot of sense for them to alternate the 4910 code with the Profi code, which is this D1110 code. So I'm not certain why this was put in there. So I asked the advisory council member, and he wasn't certain why that was in there as well. So my suggestion would be that we strike that bullet point from there, unless you have a recollection of why that was included in there.
When it comes to the clinical stuff, I leave that completely up to the dentist on the board. I could not tell you whatsoever.
So I have a collection of a lot of dental knowledge here that is indicating that we should strike that bullet point from the program guidelines.
Okay.
so I'm going to
That comes
repeat on
later.
page 10 of our document, striking bullet 4 may be alternated with with the code D4910 for maintenance of
Periodontally
Thank you.
involved individuals. Yeah.
involved individuals.
And it's because in the descriptor for the code D4910, so whatever page that's on,
That's on 18.
Thank you.
thank you. There is a description there, this first bullet point, up to 4 times per fiscal year for client. So that basically means the patient is covered, so that there's an appropriate stipulation the patient's going to get the care that they need in this benefit already. So they don't need to alternate between the two codes.
It is so wonderful having you and on this committee and doing the work and due diligence you do. and
I'm
we
happy to be able
appreciate
to
it.
help. So.
Everybody's shaking their heads.
And I get paid in granola.
And I pay you in granola. This is true. All right. Anybody else have questions, concerns, comments? If not, I would take a motion that includes the correction. have a sheet. Oh, wait, we do. I'm sorry. I forgot. We have testimony. It's the new year. And we do have somebody to testify. So Phyllis Hirschfield from Colorado Gerontological Society. I don't know why I'm having so much trouble with my syllables today. Welcome. Good morning.
Good morning. We're a grantee under this program, and so we're just here in support of adoption of this emergency rule. We especially appreciate Chandra's efforts in terms of keeping up to date with this so that we as a grantee and the seniors that we serve under this program don't have to suffer any interruption in their services or delay. So we're just here to support the rule change, and we really appreciate Chandra's efforts in this behalf. And this is totally off the record, but we just would like to express appreciation to the board. We have had several seniors who have been able to take advantage of the immediate denture addition to the procedure codes. And so they are just so grateful, and we were really, really happy to be able to offer to them. So that's all. Thank you.
Thank you so much for your comment. And Chandra, just bask in that compliment. You know, don't always happen a lot, so we really want to appreciate that moment.
Well, thank you.
Okay.
So I did want to ask really quickly, if you
Yes,
don't
ma'am.
mind, if we want to hold off on passing the deletion of the fourth strike until I can get with the dental advisory committee and let them know everything that's going on, and then come back next month. And I want to see if the committee is okay with that, if the board is okay with that.
I think that's fine. I think that's fine.
Does that cause any delay to the?
Oh, services. Good
Yes.
point.
No, it should not, because
Yeah, because we've got another month in the emergency rule, right?
Okay, so we have another month on the emergency rule. We're looking at everybody. That's what we're
and
doing.
actually this works out well because we do have another one that was emergency voted in, and we can also include that. So there's no discontinue in the services that the seniors are receiving. So
Great. Then I withdraw my request for a motion. David?
Do you need to continue?
Mr. Potts?
Do you need to continue it?
Do I need
Just
to
Motion
say
to
continue it?
continue.
table it for a month.
Yes.
We're
then,
gonna
Madam
table
Chair,
it.
I would make a
you.
motion that we continue document 101 MSB 1710-05A until February 9th of the Medical Services Board.
Great. So,
Second.
thank you. We have a motion and a second. All in favor?
Aye.
Aye.
Opposed? Abstain? So passes. Thank you so
Thank
much,
you.
and we'll see you next month. Okey doke. So I need a closing motion for the rules agenda. Boy, was that busy. That was just so hard. Yes, Mr. Potts. I'm giving doctors again. This is
No,
fun.
I'm not one of that level.
Okay.
I'm just way down here. Madam Chair, I would move that the rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meeting meet the criteria of the State Administrative Procedure Act, which are incorporated by reference.
Second.
All in favor?
Aye.
Opposed? Abstained?
Aye.
So passes. Thank you, Dr. Fraley. Okey-doke. So we are in open forum. Do we have anybody that is wanting to testify? So we don't have anybody in public comment. So we're going to go on to department updates, and Gretchen Hammer is going to give us a SMART presentation.
Did you have the SMART Act?
Awesome. So
No, that is Ruby's No Wrong Door.
We didn't get the SMART Act.
Electronically, I
Yeah.
don't have it.
Okay. Is it on our website, Dan? Can you find it? No, you don't have access? All right.
So this-
We'll walk you through it and then we'll get
Thank
you.
you.
Yes, thanks,
Thank
Kim.
you.
Thank you.
Sorry about the miscommunication. So what I wanted to do, as opposed to giving you the sort of general update, is we are required by state statute every year to give an update to the committees of reference for the department called our SMART Act. Every state agency is required. And it really is a sort of tour, if you will, of the department's activities and performance over the last year. I have that in front of me in my notebook, and we'll be working in the next 5 minutes or so to try and get you all copies of that. It is available on our website. It's been a public document, but we'll just make sure we can get access to you all. Really, the whole goal of the SMART Act is to touch on the work that we've done over the last year and to give the update to the General Assembly about the department performance plan and sort of hot issues. Interestingly, the hot issues that we highlighted during our SMART Act hearing are opioids, commit, and CHIP, which was what we would have talked about anyway. And so I thought, why not give you all the whole thing? So just wanted to do that. I will move quickly. I know we've only had a little bit of rulemaking today, and there's some other presentations, so I won't belabor my presentation, but it's really a good opportunity to leverage what the department staff worked so hard to put together. The first thing that we wanted to share with everyone, and I have a copy of it, and we can also make sure you get copies, is something from the Commonwealth Fund. You know, we spend our days administering a program and making sure it has sort of sound stewardship and good policy and those kinds of things. And you all obviously play a critical role in helping us do that. The Commonwealth Fund obviously takes a little bit of a different perspective and tries to understand what's happening nationally as it relates to health improvement for communities. And Pueblo, Colorado was one of just 14 out of 306 regions nationally to improve on the variety of performance measures tracked by the Commonwealth Fund and their scorecard. And really one of the underlying stories in that great effort by Pueblo is Pueblo to really improve the healthcare system performance. And so, again, only 14 out of 306 states moved as much as Pueblo did, and we believe Medicaid's a key role in that movement. So we'll get you that, but we shared that with the legislature because, again, as you all know, we get down into the details of whether or not code 4910 is the right code, right? And that's where we should be. But every once in a while, it's great to be reminded nationally what's improving. The other things that we talked a little bit about is that the Colorado Health Access Survey came out, I believe, in October or November of last year. And the real headline of that was that we were holding steady. So 93.5% of Coloradans are insured, which is a tremendous movement. The most people continue to get their health insurance through their private health insurance. So 58.2% of people still have private health insurance. Medicaid and CHIP make up about 20% of the state's population in terms of insurance coverage. Medicare, about 14.5. Dan, you're a master. It's now up on the screen. Again, this was also publicly shared. Unfortunately, it was shared the day there was the shooting right near the Capitol. And so it was like you were either in or you were out because there was a lockdown at the Capitol. But Medicare and then the uninsured is about 6.5%. What we know about low-income Coloradans in particular is that health insurance may not be a static state of being. There can be a lot of movement. This question asks specifically in the Chaz is, on this day that I am calling you, do you have health insurance? They also have a statistic, though, that shows over the course of a year, did you have a period of uninsurance? Now with the individual mandate and some changes to the private health insurance market, that number is getting smaller. But that number is a much bigger number when you ask, have you had a period of uninsurance over the course of your year? And we know that if you have an accident during that time or a terrible diagnosis or something, that can be terribly difficult for families to manage. The other thing we talk about with the legislature, which you all know about as well, is that there are many programs that are administered by the department. Obviously, Medicaid and CHIP are the biggest, but we have the Colorado Indigent Care Program, the Old Age Dental Program, the Old Age Pension, medical programs, et cetera. So a reminder that we are healthcare policy and financing, not just Medicaid, and we have a lot of special financing programs that we manage as well. The next one is a interesting just reminder of who is served by the state of Colorado. And Kim was asking to be refreshed just this morning of, you know, what is the income level? So for a family of one, so a single individual, they can't make more than $16,000 a year and be eligible for Medicaid. So that's not a lot of money, especially in high cost regions of the country like Colorado and in particularly the Denver metro area. And then for a family of 4, that income level is $32,724. Again, it can be quite challenging to manage a family and childcare costs and transportation costs and housing costs and all those other costs that families need to deal with. So an important piece there. We also track, and this is something that obviously when we visited Salida is important, 21% live in rural areas and 79. That tracks with about the way the state is cut overall. It's 80-20-ish. But interestingly, 16% of Colorado Medicaid members live in Denver County. We have county fact sheets on our website that if you want to look at your own county, at least a year ago or so, we spent $1 billion in the city and county of Denver alone as a Medicaid program. So when we look at rural communities and think about the economic driver that the healthcare system is, Medicaid plays a significant role in that. The other thing that's on those county fact sheets, if you're interested, is the top 5 areas of expenditure. They tend to waffle between hospital, pharmacy, those kinds of things, but there is some variance. And so those county fact sheets are online. The next slide really talked through CHIP. You guys have heard me drone on about CHIP for about the last 6 months. The numbers don't vary much. We have about 75,000 kids and 842 pregnant women. I think one of the reasons we shared this slide is just as you think about what options might need to be available for kids if the CHIP program changes. There's babies, there's adolescents, there's a variety of kids who may be served better or differently by different private products that may be available in the exchange or from their employer. The next slide, we really just share always with our members of the General Assembly to remind them that in places like Otero County, that 43% of the people who live in that county are enrolled in Medicaid. Obviously, Douglas County is the smallest with 8.2%, but you'd be surprised at the number of state legislators who still say 8.2% of the folks in my community are enrolled in Medicaid, and we say, yep, that's what our data shows. In conversations with folks, also it is a reminder that the living wage and the levels of poverty in some of our rural communities are part of what drive this, in addition to the availability of other health insurance products and others. But you still have to income qualify or through your disability qualify. So variance, which is just important for us to remember in terms of the impact that Medicaid can have on the economics of a community. And then this is really where we spend a lot of time usually with the Joint Budget Committee and others, is explaining the sort of interesting notion that, for example, children and adolescents are 41% of the population that we serve in the Medicaid program. But because on average, most children are fairly inexpensive to provide health insurance for, they only account for 18% of our expenditure. So when we think about the kinds of things that Kim just charged us with appropriate services and cost containment, it's important to understand that. What is often the headline here is that about 9% of our population represents a significant portion. So 6% of our population are individuals with disabilities, and 3% are older adults. And they reflect, so together that 9% reflects about 45% of our spending. So again, to think carefully in the Medicaid program when thinking about cost containment, that some of the costs are those individuals who are who the Medicaid program was designed to serve, and really what is the unique part of the program in terms of long-term services and supports, and support for individuals to not live in institutions but in community and with the right supports. So the non-expansion adults also always sort of under expend, which, when we have that debate, the expansion adults were 34% of the population and just 25% of the spend. And so just these nuances help us to understand where we have the opportunity to improve the program. The next one, and we don't have to stop at all of these, but Medicaid funding, with the change in the federal financing as we expanded Medicaid, the federal government actually pays 60% of the costs of Medicaid. Our typical match is 50-50, but there was an expanded match. And so general fund is smaller, hospital provider fee, and then cash funds. So other states, federal match is based on the economics of your state. So poorer states, like in the South, often have a higher match rate, 75-25. States like Colorado with robust economies tend to be at 50-50, but we have a little bit of a shift because of the financing.
Was that because of the Affordable Care Act?
Yep. So this one is always a slide where we spend a little time, and that's where the money goes. So it can be very hard to put your mind around a $10 billion budget. And a couple years ago, we observed that people sort of wondered where that 10 billion went. And so we put this bubble chart together and have been using it ever since. And $2.5 billion out of the Medicaid budget goes to hospitals. And that represents actually about 10% of the entire state budget goes to pay hospitals in the Colorado Medicaid program. Nursing facilities, physicians' clinics, pharmacies. The pharmacy part's always a little tricky because of the federal rebate, makes that math a little more complicated. Durable medical equipment, et cetera. So this is really we've found helpful to help folks know that, you know, the state doesn't just not spend the $10 billion on health services. In fact, most of what we spend goes to making sure people get access to services, and that's the breakdown of where those services are received. So the governor's dashboard, I think just because you all serve on our behalf, there are some specific health goals that the governor has identified. These are not exclusive to the Medicaid program. So Department of Public Health and Environment, Division of Insurance, Local Affairs, we all sort of, anyone who has a little bit of health in their mission is held accountable to helping move these forward. And so CDPHE, obviously Department of Public Health and Environment. So we play a role in some of them, but other state agencies also take the lead on some. Our department performance plan, we're required by state statute to submit a department performance plan, just like every other state agency. We've identified 3 long-range goals: improving the health of low-income and vulnerable Coloradans, enhancing the quality of life and community experience, and reducing the costs. We have metrics for those that are 3 to 5 years out, but we also have yearly metrics, as you might imagine. And then we've got 4 strategies. I won't read them all to you, but we call them, because the state requires us to, strategic policy initiatives. These are the places where we're leaning in to help move the Medicaid program forward. Delivery system innovation. Tools of transformation is that commit project, that if we're going to have new tools, that we should use them to the best of our ability. Again, we believe we have a role in population health, but so does CDPHE and so does the Department of Human Services and others. So through partnership, we get there, and then trying to be operationally excellent. The other ask that we were always trying to do is how we've improved customer service. And this is actually something we're super proud of. You all have been through the weeds with us on the Commit project and heard from providers who really struggled. But one of the cool things that all that struggle got us was a more sophisticated provider search engine. So this provider search engine now comes directly from enrolled providers. So it's updated twice a month by the system. So if you're an enrolled provider, it also only shows providers who are actually enrolled in the services that they can provide. So no more confusion of, I think you can help me here, and the provider says, well, maybe I can. No, and now it's all lined up. You can search by zip code, part of an address, by the service that you need, whether or not they're accepting new patients, some cultural competency related things. We've had 220,000 searches have been performed, and this tool is consistently the most popular page on the HCPF website. So we know the exchanges and the private health insurance and everybody has really struggled with this task. We are really proud of it, and providers do have the opportunity to say they don't want to be in the directory, and so we have about 42,000 providers listed in the database. So, about 10,000 or so who say, please don't put me in the database. I accept Medicaid, but I am full, or I don't really want to be advertised, or whatever their other reasons may be, which we honor. But this has been a really important piece of helping people access services. All right, major initiatives. You guys have heard us drone on and on and on about the Accountable Care Collaborative. We are pleased to share with you that the second phase of the Accountable Care Collaborative had a successful procurement. So we did a statewide procurement, 7 entities were chosen. And so we have now the next phase is really this single regional entity to bring into alignment physical and behavioral health services, strengthen the ability for coordinated care, et cetera. And so we are well on the path. We are in contract negotiations with those 7 winning entities right now and on track to begin the next phase of the Accountable Care Collaborative in July of 2018. Here's who the winners were. We had, again, 7 regions. We went from 7 physical health regions and 5 behavioral health regions, smunched them together. There were only 2 counties that weren't aligned. So we now have 7 regions and these 7 entities, groups of entities who are contracted. You will see Colorado Community Health Alliance was awarded in 2 of the areas, as was Colorado Access. So all in, we have 5 vendor partners, but they have responsibilities and are sort of treated independently in their areas for each of the places that they bid for. So very excited, very big procurement, and really the staff did an amazing job trying to move that forward. Do y'all have questions at that point? I'll keep on going then. So this has been the previous structure of the Accountable Care Collaborative, really just focusing in again on that patient-centered medical home, regional care coordination, and then data to support. We did continue to see in our current structures performance. We are required to submit an annual report to the legislature every year. Well child visits improved. Dr. Fraley, thank you for your service. Well child visits for 3 to 9-year-olds improved. Postpartum care rate increased. So number of women who see a provider within 30 days of postpartum. And then ED utilization continuing to go down. So those are all things that give us a sense that when you make sure people are connected to a primary care medical home, have some regional support in navigating if they need it, and everybody has the data they need to support the process, things actually do get better. Can we improve more? Yes. Are these the perfect measures? Probably not. We could have that healthy debate, but at least it's a move in the right direction. All right, so long-term services supports. The next speaker that you're going to hear is Ruby, and she's going to talk us through a really innovative approach that we're taking in long-term services and supports. But this is also obviously an area where President Blakely has a lot of experience. So long-term services and supports are the part of the Medicaid program that support individuals with disabilities. It can be across a continuum. We often talk about home and community-based services, but I think, as you may recall from the debate about Medicaid over the summer at the federal level, Medicaid is one of the largest payers of nursing facilities and Donna can confirm, in the nation. And so there is at home, in community, and within institutions. So both nursing homes as well as intermediate care facilities. Those are all individuals who are served by our long-term services and supports. This is who receives these services. So of the individuals who are served by our long-term services and supports programs, 7% of those children are adolescents. So, or are children and adolescents, 44% aged 21 to 64, and then 49% older adults. So again, when we think about the policies that are in place, it's not just long-term services and supports are not just for adults, but very importantly for children and adolescents as well. Here are the 11 Medicaid waivers for home and community-based services. Again, waivers are counterintuitive, in my humble opinion, in the Medicaid program. Typically, you waive something to do less. In Medicaid, we waive parts of the Social Security Act so we can do more. And that really allows, for example, our spinal cord injury waiver or our brain injury waiver, children with life-limiting illness waiver. We can provide additional services to individuals enrolled in those waivers that we wouldn't provide to the entire Medicaid program. All waivers require that they be cost neutral. So the argument being, if we provide additional services to folks, they would not live in an institution, and therefore, one, they'll be more integrated into community, and two, it would be at least cost neutral, if not cost savings for the department. So bit counterintuitive, but waivers are typically services. Colorado has 11. That is a high number for other states. Many states have 2 or 3. And so we have a long history. We used to have 12. There was one for individuals living with AIDS. We combined that. And so individuals didn't lose services, but combined that with a different waiver, so that the elderly, blind, and disabled waiver, so that that we can continue. One of our tasks is to continue to make this less difficult to navigate for people, which is really the next slide for you. So the governor himself committed directly to long-term services and supports with an executive order back in 2012. He created the Office of Community Living within our department, and a process, long-term stakeholder process called the Community Living Advisory Group. And it really was to take to charge the agencies and the state to say, long-term services supports are important to people. They're a little bit complicated and difficult to navigate. Let's get together and work on that, allow people to live integrated in community and have the supports they need. So really, during the budget hearing, there's a new budget analyst, and it's always wonderful to see people try and put their head around Medicaid. And so she created at the time, which was an appendix in her budget document, which was just a laundry list of all the things that are being done in this part of the Medicaid program. And she was like, this is a lot. It's really complicated. And so there was a little bit of concern by the Joint Budget Committee. And so we worked really hard to put this slide together, which is to say, no, it's all good. We know exactly what we're up to over here. They really do bucket into streamlining access to services, improving service coordination, and increasing the service options and quality. And so what you see here is what was in our JBC budget analysts appendix that we were just trying to bring some structure to. So the very first one you see under streamlining access to services is the No Wrong Door program. And that's what you're going to get the second presentation today about. A lot of the big green things are things that we've been working on and are active. Some of these come from federal regulation. Some of them come from state regulation. Some of them come from recommendations from the CLAG or other things that we've done here. And then also there's these sort of notions of operational excellence, of sort of how do we also just do this work well? And so that's what this really slide was about. And it encompasses all of the major initiatives that relate to improving our long-term services and supports. Yes.
Community
Living Advisory Group. Yes, the CLAG.
But you didn't say CLAG.
Thank you.
said CLAG without that. And I just
Thank you. So now we're just going to, again, stop me if you have questions. We just felt like this was a really great opportunity. Yes, ma'am.
We are going from 11 waivers to 10 waivers as of July 1 with the removal of the autism waiver because it's now in state plan.
Correct.
So just.
Yep. So there was a waiver that served children with autism. With some changes of interpretation by the Obama administration, there was a desire that one of the services that was available in that waiver be available to all children enrolled in the Medicaid program. So we made that shift programmatically. One of the requirements of the waiver is it has to be services that are unique, right? That's the point. It's a unique set of services. So without that uniqueness, that waiver really didn't make much sense to manage. It also was limited to 75 children and only up to the age of 8. And so there were some other provisions in that waiver that made it cumbersome, although it served people very, very efficiently and appropriately. We're allowing each of the currently enrolled families to age out of the waiver, so we didn't just stop it. We've got a transition plan, but the reason it's going away is because those services are now more broadly available to all children enrolled in the Medicaid program. So the other just one piece that's important is being enrolled in a waiver also gives you access to all state plan benefits. So if you still fall and break your leg or, whatever that is, you have the full benefit. Many of the children enrolled in the waivers have additional insurance. through their parent or others, but use Medicaid as secondary insurance, and adults too, for durable medical equipment and home and community-based services that may not be available through private health insurance. But we do have many individuals who are duly insured, and Medicaid is the payer of last resort in that. Did you have anything? Yeah, David.
How many families do we have in the state enrolled in Medicare?
In Medicare or Medicaid?
I'm sorry, Medicaid.
Families, well, we have the number of individuals enrolled, and that's about between 1.3 and 1.4 million Coloradans are enrolled in the Medicaid program, and 45,000 or so are part of the services we were just talking about.
Well, in that, and you don't have to go back, Dan, but one of those slides, a family of four was to be eligible for Medicaid had to be below roughly $33,000.
Right.
And the statistic for housing, you have to be able, if you're going to survive, you have to only spend 30% of your gross income on housing. That's $9,100 a year. There's no place in the state you can live for $9,100 a year. So I'm just trying to wrap my head around some of these figures and how they work.
That's why we're doing
What happens. That's why I was curious how many families are living in this, and it's not even classified as poverty.
Right. Yes. And when, especially, we also know that there's some data, I think, that shows childcare is the most expensive. That may not be true statewide, but certainly in the Denver metro area, one of the most expensive areas in the nation for childcare. So yes, there is a constellation of things that make it very difficult. The other place, and you experience this given your county, the other challenge that we have heard specifically in our rural resort communities is individuals to just get by living, for example, in Summit County, may work 2 or 3 jobs or those kinds of things, but their wage is really required to probably be closer to $40,000. And that still makes them only able to sort of get by, but it doesn't make them eligible for Medicaid, which is why the exchange was such a great promise in that area. But the health insurance rates are so high in that. So there's this real conundrum between, especially what does it look like when we have a statewide, actually federally dictated standard for income eligibility, but the variance in costs in communities can be so great that it can make it very challenging.
What is CHIP?
CHIP is $60,000. So the federal poverty level guidelines for CHIP are between 138% of the poverty level and 250%. So it is a higher level. And there's a little more cost sharing and some other more like private health insurance provisions in the CHIP program. There's an enrollment fee. The co-pays and other things are a little higher for CHIP families. So it was originally designed to be sort of that bridge between fully subsidized and then mostly fully subsidized, but with a little bit more responsibility among the families. And then I think the challenge we have faced in Colorado is the next step into the private market is just so vast, right? In the CHIP conversation we were having, I had the chance to talk to a mom who has a single child enrolled in CHIP, and to add him to her employer-sponsored coverage was $300 a month, right? So that's just a significant jump from she was insured by her employer, but when you add that child, it becomes a family policy, regardless of how many there are, but you add them. I never understood that, but you add that child, it becomes a family policy, and that difference can just be.
Gretchen,
Yeah.
the Colorado Center for Law and Policies puts out a document that kind of breaks down by county your like self-sufficiency wage.
Yep.
And they haven't updated it in a few years, but it's helpful to kind of understand where in the state the living wage number is.
Yeah. Yeah.
For extra data.
Yep, that's exactly right. And I think there's a lot of folks who have tried to say that the notion of the federal poverty limit as defined is a little antiquated. The method by which, and I'm not the expert here, but the method by which it's calculated and other things probably hasn't caught up to the economy that we live in today. So as Kim said, one of the other areas that we're really working on, and you all touch this sometimes in your work with us, is as it relates to value-based payments. So, you hear often that we got to stop paying for volume and pay for value in the healthcare system. Everybody's trying to bite at this apple, and there's no silver bullets, and feds are trying, states are trying, private industry's trying. So Medicaid's trying too, and we're doing that with our hospitals, our federally qualified health centers, primary care, and within the pharmacy structure. What that tends to look like for us is putting some of the payment into a pool and doing performance enhancements. So the Accountable Care Collaborative, we hold back a little of the money we would pay to the providers. And if they hit those metrics of the well child visit or integrated care or those kinds of things, then they can earn a bonus. So there's those are some of the areas in which we've been working, and we've been working really hard with primary care as we look at trying to increase the ability and flexibility for primary care providers not to have to always see people in their clinic, which can be both inconvenient for the patient and sort of not always the best use of the provider's time, and give everyone the flexibility to do more population support and those kinds of things, and not have to generate that through a physical visit with an individual.
So how does that relate, excuse me, Madam Chair? How does that relate to cost-based payment, like we were presented with from Bob Morosco on emergency care? Or is this even close?
I think it is related. I think that when one of the things the larger healthcare system is struggling with is why are costs so high to begin with? And so, yes. And so it can be that when we're locked into a cost-based structure, we don't have as many tools to drive value. Now, that doesn't mean they're mutually exclusive. We've had a great partnership with the federally qualified health centers who have some cost-based payments based on their federal protections of the way they're paid. And we've been working really hard with them to also innovate within that space in a great collaboration. So it's not to say that there isn't opportunity to do value-based payment, but it's having a lock-in on cost when we still don't probably have all the transparency we need as it relates to healthcare cost can limit our ability to do some of that innovation.
Okay.
All right, next is hot topics, which you guys have heard a ton about, but opioids. Like I said earlier, there's a whole bunch of stuff that the governor has been tasking people to work on. CDPHE has played a critical role in this work, Department of Human Services, all kinds of folks, Department of Public Safety, others. But this is the work that we've done as it relates to opioids. One of the things that we really were pleased with was in 2017, I'm already ready for 2018. In 2017, Dr. Zerzan and her team worked to do some quantity limits on short-acting opioids. I think I might have updated you on this. We made some changes to what would be allowable for getting a prescription because we had some data that showed if you hadn't had an opioid prescription and then you got one, you were maybe more likely to end up in some trouble as it relates to the overutilization of opioids. And so if you were opiate naive, there was a limit on the number of opiates you could get for a dental procedure or a elbow procedure or whatever procedure you might need where opiates would be required to help you manage your pain. And we've seen in early claims data a reduction in the number of prescriptions, which is a good thing. The other place that we've been working a lot more is as it relates to long-standing and individuals with chronic pain needs and how they use opioids to help control their pain. So the policies were slightly separate, but we've been working off both of ends of those. The thing that's awkward for us in this work is we are both the provider of the opioids, and then we are the delivery system that supports individuals who may end up having an addiction or have found themselves addicted. And so we've been trying to tackle it with using both sides of that part of our responsibility. What's a responsible prescribing policy? And then what's the right supports that need to be in place for individuals with all kinds of substance use needs, but also those who are addicted to opioids. All right. So I am happy to share with you that the Colorado Interchange, the COMMIT project, has very, very rapidly been approaching normal operations. So we sort of said normal operations would take us 6 to 9 months to get there. We're 9 months into the launch of the program. Going to see it here, but we shared with the legislature the number of providers requesting interim payments has plummeted to 0. So I think last month it was 1, so I shouldn't say 0, 1. So people really are able, seem to be able to get their claims paid in the system. We've had providers start to pay us back, which is exciting. When we gave those interim payments, we did not start to put constraints on when you would owe us the money back, but providers have said, we are good now. We're going to give you, we had a provider give us $2.5 million back the other day. So very exciting. Is it perfect? No. Is everybody singing? No, but we're closer. And we have now a series of claims that are still in suspension, but that number I think Chris shared at the hearing is about 40,000 claims that are sitting in suspension. And we anticipate normal operations is that we'd always have about 30,000 claims sitting in suspension. And suspension just means they're not going to auto pay. They need a human to look at them and confirm they're right or clarify something or some other things. So really have made some improvements. This slide just represents where we did put 7 field reps. And so the one thing is those stars are not perfect. Chris said it was only where I could fit them in between the county names. So they're not 100% reflective, but they are to some extent reflective of where we have these field reps who are out working one-on-one with providers. Our teams have started to do road trips, which I know was critically important when we were all out in Salida, how just important it is to go out there and sit down and hear about it. So Chris this week was in Hugo, Colorado on Monday, which is not a place that is frequent on the sort of tour of Colorado, but really important. And Chris, and his team have gone out there. We've also taken the chance to go to some provider association meetings and have what we call office hours, which is our technical staff will sit in a conference room outside of the normal conference, and anyone with a technical challenge can come in and talk to them directly. So we've also gotten some feedback that that's a really helpful. We're doing that with the Colorado Hospital Association, Colorado Rural Health Center, federally qualified health centers. Yesterday, I think we had office hours. So we have learned that we needed to be out and holding hands with providers a little bit more, both through these reps and through our own technical staff. All right, and then CHIP. So I will end here because after this, well, there's a budget request, and then I'll turn it over to Zach Linkowitz, our legislative liaison. The update on CHIP is there's been some movement. There's been 2 areas of movement. After our presentation to the Joint Budget Committee, the Joint Budget Committee asked us, what could we do? And we said, well, one thing that you could do would be to give the department spending authority, and I'm not going to get the perfect terms right, so if you're listening, budget folks, sorry, to give us some additional appropriation and spending authority to spend state-only dollars to preserve the CHIP program if Congress hadn't acted. The governor actually had to request that. The Joint Budget Committee took action. So we do have some state resources that will come out of the CHIP Trust Fund, which is a cash fund. You mentioned there was that little cash fund square there. So that is available to us. We haven't needed to tap that yet, but it's good to know that we don't need to end the program on January 31st because we have that in our back pocket. At the same time, Congress acted through a continuing resolution. Clearly, no one in Congress has ever run a public health insurance program because 3 months continuation is about the worst we could have asked for from a technological perspective and from a program management perspective. We've identified we have over 50 contracts that would have to be modified at the point in time in which, right? So this just logistically, but we're appreciative. We always say thank you. So in that, there was an additional $45.5 million shared with the state of Colorado. The problem is if other states run out of money first, those funds could be taken from us and given to those other states. So we can, to some extent, bank on that $45 million, but not all the way. So all that means that we are able to continue the CHIP program after January 31st. We're working on official correspondence with clients about that. Congress is set to, again, potentially act January 19th or 22nd or sometime, the Congressional Budget Office came out with a revised score because of the changes to the individual mandate in tax reform. The CHIP program over 5 years will now only cost $800 million as opposed to $8.2 billion. The theory being, and I've tried to understand it a couple times, so that it'll be more expensive to buy health insurance in the marketplace, so CHIP's going to be cheaper. I haven't quite put that all together in my head. And if you go out 10 years, the CHIP program is now estimated to save the federal government $600 million. So I can't remember the number. Okay. That's why I flubbed it.
Okay.
So some money. It's going to save over 10 years now. A lot of money. So that then leads this sort of, it's a new wrinkle, right? When it cost $8 billion, a little more difficult maybe to find. If it's just $800 million over 5 years, there's some perspective that Congress should be able to find $800 million to continue the program. I have lost my ability to bet on this, though. So we are proceeding with knowing what we have available in these what are called federal redistribution funds, and what we have due to the generosity of the Joint Budget Committee, and looking to see when we could run the program. The other piece that's just important is all of this stuff over the summer was when the General Assembly wasn't in session. So we were a little bit hamstrung there. Now that they're back in session, that also just opens up the legislative branch having some perspective that would be important to the conversation. So that's really where we find ourselves. The facts as we know them today is we'll be sending out some correspondence about not ending the program on January 31st, and trying to give folks some assurance of when we can manage the program, knowing that the federal government always has the ability to take some of the federal money away, makes that difficult. So that's where we are. Questions? Brigitte?
Hey, Gretchen, this is Cecile. Can you guys hear me okay?
Yes, ma'am.
Okay. Hey, I just wanted to say how much, I'm going to speak for the Western Slope pediatricians, how much we appreciate all the different groups, including HCPF, working on this. I just boots on the ground in my practice, which has, I think, about 700 plus kids on CHP. Every kid that I have seen since mid-December, every family, they know about CHP changes.
Great.
So I feel like that's been very successful. I know there's been sometimes pushback about, not from providers or patients, but other pushback maybe about letting people know too soon. But I think families are really appreciating it, and people are trying to get in and get stuff taken care of.
Great.
Before, the February deadline. So we appreciate that. And then just a comment kind of for the board, and this is with my hat on, pediatricians are taking a lot of hits right now. We have 20 to 30% cut in Medicaid that is federally guided. And then for most of us, I think CHP, at least in the rural practices, it makes up between 5 and 10% of our practices. Medicaid for many of us is between 35 and 50%. So it's just, it's a lot, and we hate to see these families go without insurance. So that's just a plug for appreciating what everyone's doing to keep the kids covered.
Appreciate those comments, and we always love having you remind us of the other corners of our state that we sometimes forget here in the metro. So thank you. Brigitte, you.
I was going to repeat some of the same things that Dr. Fraley did, that we see increase of folks trying to get their coverage, get things taken care of now. So that's good. And another question I had or comment is understanding that we have a possible extension with funds from the feds, I think you were saying, but that's that shared cost of $45 million. Which pot do we use first?
No, that's a good question.
Yeah. So we use the federal money first every chance we get. No, I'm just kidding. The federal program, or the federal match rate right now for CHIP, is 88%. So that is one of the other reasons why the loss of federal financing is so difficult to make up on the state side, is that it's at an 88% match rate. So still today and every day, every dollar spent in the CHIP program, whether that's for the capitation to the managed care organization, which then pays Dr. Fraley, or whether that's for the children covered in the Medicaid program but who are financed by CHIP, For every dollar spent, 88 cents of that is federal and 12% of that is state. So we don't get to change that formula. It's not like we get to say, we're going to preserve all state dollars and just use federal dollars. That percentage is there. We, for the state share, use that 12%. Comes from a couple different places: the general fund, the cash fund, and then actually a provision in the hospital provider fee means that we spend some of those dollars that come from the state share are hospital provider fee dollars. For the 205 to 250 for children and pregnant women. So we use a variety of sources for that 12%. It's not all general fund, but some is general fund as well. So that's why, the first time we tried to put a slides deck together for the General Assembly explaining the options, Representative Rankin was like, back it up, like way, it was like 18 different cells and everything. So we've been trying to sort of figure out how to communicate. It's pretty complicated on the financing, but that percentage continues on. The risk is with the end of the program, there's these kids covered by the Medicaid program, but financed by CHIP. They will not lose their coverage, but the financing on the back end will change. And so that would be a significant change to the use of the general fund, because we would go from 88% federal financing to 50%, back to our traditional Medicaid match rate. So that's been another portion of what makes this complicated. Did I just confuse everybody?
That's a lot.
David?
Just curious, knowing the federal government the way I do in other areas, how did we get a reserve when other states, they ran out of money September 30th? I mean, they didn't have any to go forward into the federal fiscal year?
Yeah, so it's a great question. There are a couple of different answers to it. Some states have always seen CHIP, and in our state as well, as more of a public-private partnership, not an entitlement, et cetera. So some more conservative states have used their CHIP program, and so they have a lot of people enrolled in the CHIP program. Others have the limits of those CHIPs. So it's really relates to the way the CHIP program operates within the state.
Different standard.
There are different standards. So there are many states where Medicaid eligibility goes to 200% of the federal poverty level. We don't have, 138 is the bottom. That number could be higher should the General Assembly ever want it to be. So there are many states who have, and in fact, for pregnant women, it's 185%. It gets complicated. But to some extent, it depends on where the CHIP program is in their state sort of infrastructure of public health insurance that matters. Some of the ways in which they use those dollars, a lot of states don't have a standalone CHIP program like we do. Those kids are all covered in Medicaid. And so they use it to fund the Medicaid like we do for that group. So the variance is to some extent in that area. But I believe Washington State and Utah, a couple of our state colleagues here in the West, have run out of money very early in their program. All right, so last slide before I turn it over to Zach. Budget requests. So was there one more question? No, okay. So
be good stewards.
The budget request is, these are the things that were included in the governor's budget as it was presented in November. They are on whole cost savings. So we obviously have an increase because of in our medical services premium, which is, you see we start at 6 here, our 1 through 5 are parts of sort of the core functioning of the Medicaid program. But in our areas of the discretionary budget, they really are focused on ensuring program compliance, achieving cost savings, and targeted program improvements. There are a couple of rate adjustments that are also in here. Some of those are not necessarily cost savings because we're proposing to increase rates for folks, but on whole, the request reduce general fund expenditure. So if anybody has particular questions about any of these, I'm sure that Josh Block, who comes to us often. He's on vacation this week. Good for him. It will walk us through these over the course of the legislative session once things start to get moving. But these really are some of the things that are moving forward. Some of them have a corresponding piece of legislation, which is where Zach comes to the table and can walk you through our legislative agenda.
That was good, Gretchen. Thank you.
You're welcome.
you.
I figured we do this, we put all this stuff together. It might be useful to share with you all. Good, I'm glad.
Oh,
Will we have access to these slides? Okay,
Yeah,
good.
I'll
Thank you.
send the link
that would
out.
be very helpful. Yes,
Thank
thank you. And Zach, we say happy New Year and welcome, and it's nice to see you this morning.
It's good to see you as well. It's been a while. So, good morning. I think it's still morning. My name is Zach Linkwitz. I'm the department's legislative liaison. And as Gretchen mentioned, I'm happy to walk you through our legislative agenda. And I think Dan's handing out an overview of the bills that we're running this year. Yes.
I have an extra. Do we run out?
4? Okay. So I'll just go down the line, and if you have questions at any point, just let me know. So the first one's around the redesign of the Children's Rehabilitation Residential Program waiver, which is also known as CHIRP. As discussed in the SMART Act slides, we have 11 home and community-based waivers that serve children and adults. This is the last remaining waiver that's administered by the Department of Human Services. And so this proposal will do a few things. It also has a corresponding budget request. The first thing, it will move the administration from the Department of Human Services to HCPF. It will also change the eligibility criteria so that families don't have to give up their parental rights in order to get the children the services that they need, because there's a requirement that children be involved in the foster care system. And so families, I've had constituent issues where families are sort of forced to make this very difficult decision to give up their guardianship rights in order to get the child the needed residential services. And so we're asking to remove that. We're also asking to change the case management from the counties to community center boards or their successor agencies who have more expertise in dealing with children with intellectual and developmental disabilities. The counties have generally expressed that they don't have the in-house expertise to deal well with these children. So there'll be some coordination if the child is involved in the foster care system on its own, if that makes sense. But generally the health case management would move to the community center boards. The next one is around conflict-free case management for single entry points. So we ran a bill last year around conflict-free case management for the community center boards. The community center boards serve people on the intellectual and developmental disabilities waivers. The single entry points serve clients on the waivers with people with physical disabilities. And there's a similar issue with 4 agencies in the state that have this conflict. And so we need to make some statutory changes to make sure that both systems comply with the federal rule in ensuring conflict-free case management. I assume this one will be less controversial and because it's impacting less agencies, but generally single entry points are managed by the counties. The next one is around cost savings through transition services and community living. So there's a federal grant program called Money Follows the Person, and in Colorado we call it Colorado Choice Transitions Program. The goal of the grant or the program is to identify clients that are living in nursing homes or institutions that are interested and able to move back into the community. And we've had a really successful run using the federal grant dollars. We've made 274 successful transitions from institutions into the community, which has saved the state money. Generally, the clients have reported better or greater satisfaction with their care, and it also puts us in compliance with the Olmstead decision at the Supreme Court. The federal money is expiring, and so we're asking to use general fund to continue 4 of the services: targeted case management, home delivered meals, peer mentorship, and independent living skills, which we found to be the most effective of the services that are currently covered under the federal grant program. And if we do that, we actually we're assuming that we'll continue to transition clients from institutions back in the community, which saves the state money. So in a full year, we expect to save $6.3 million in total funds, or $3.1 million in general fund, by continuing that program using general fund dollars. The next one is around aligning managed care statutes with federal regulations. So there was a federal managed care rule that was passed, I think, a couple of years ago. We run some managed care programs within the Medicaid program, and so we need to make sure that our statute aligns with that federal rule. We created a report on December 1st to the General Assembly that identified the major changes in that legislation. I'm happy to give that to you if that's of interest, or it's on our website. And then we'll be working with legislators in terms of that technical fixes, but it shouldn't be super substantive. And then the last bill is around removing an outdated waiver reference from our statute. So the persons living with AIDS waiver served clients in a while back. In 2014, we transitioned those 54 clients from that waiver to the elderly, blind, and disabled waiver, where they could get more services but not have to apply to a waiver that disclosed their health diagnosis. So it was better for the clients. The waiver no longer serves anyone. We don't have federal authority to operate the waiver, but it's still in our statute. And so we asked the Statutory Revision Committee over the summer to run a bill to remove that reference from our statute, and they agreed. So that's our last department agenda bill. Happy to answer any questions if you have them.
Any questions? Dr. Fraley, any questions? I guess not. Okay. Thank you very much.
Thank
for
you.
Your time and
There is one
insight.
last slide.
Oh, there is one last slide.
Yeah, Dan, can you just go to the next slide? Sorry, that's that one. Yeah, this regulatory agenda one. Next one. No, sorry. No, it's okay. So this is just the one part also that was directly about you all in our SMART Act hearing. You may recall that often staff will come up to the table and say, last year, this rule was part of the regulatory review agenda, and we found a whole bunch of antiquated language and blah, blah, blah. So this is the update. We're required by the SMART Act to update them, the legislature. The first 5-year cycle began in 2013, and so last year was the first. So what you'll be seeing coming up will be either round 2 of those, or we'll just continue to be on that cycle. So over 1,400 sections of our rules have been reviewed through this process. And we are, for example, this year bringing the long-term care rules. So this, again, is the chance for us to go on a regular basis, part of the governor's commitment to elegant, efficient, and effective government, that we slash stuff that no longer makes sense in our rules. I remember, one of my first medical services board, we removed the reference to mental retardation, which was the right thing to do. So those kinds of things are what you often see. Sometimes they also reveal like, oh, we got to fix something, and then that comes through you. But we are, Chris sent yesterday, I think, to all of the staff who are in charge of rule review this year. So we'll continue this process. But that was just the one last thing that when I looked at our agenda, that was just worth reflecting to you all, because you often ask sort of, what was the journey of this rule coming to our board? And sometimes the journey begins with a spreadsheet that Chris sends out that says, this rule's turn to get reviewed this year.
And with that segue, I'm going to ask for Erin Schneider and Ruby Gonzalez to come up and give us, okay, just Ruby. Erin's going to throw Ruby under the bus. No, just that was a little humor. She's going to give us an update on the No Wrong Door and the long-term care services as we begin to look at some of these rules. So she's giving us the heads up for next month's rule. Thank you. Good morning. Happy New Year. All those good things.
Yes, good morning. Happy New Year. My name is Ruby Gonzalez, and I am the department's No Wrong Door implementation policy
Make sure you're talking into the microphone. You're soft-spoken. Use your outside voice. We like it better.
Okay. Sorry, everyone. My name is Ruby Gonzalez, and I am the No Wrong Door Implementation Policy Specialist for the department. And I'm here to talk to you about something very important that may most likely have some policy and rule regulation implications in the not too distant future. And so that specifically is Colorado's No Wrong Door efforts to try to solve the long-term services support puzzle. So this is our mission as the department. I'm sure you've seen it multiple times, so I won't reread it for you. It's not working. There you go.
There it is.
You got it. Okay. So what I want to make sure that you walk away with today is I want to make sure that you have a complete understanding of what our long-term services support puzzle looks like, and also what No Wrong Door is, as well as the No Wrong Door regional pilots, and what they're doing, our project deliverables, and our evaluation process. So this long-term services support puzzle, you cannot read, but I will highlight a handful of these organizations starting from left to right. So starting from the left, we have our Centers for Independent Living, which were previously known as our Independent Living Centers, ILCs, and they predominantly serve people with disabilities. Then in the center, we have our community center boards and our single entry point agencies, which are our case management agencies. As you may know, they do the functional assessment to determine if they're eligible for long-term care Medicaid, and respectively, they CCBs provide services to people with intellectual and developmental disabilities. Meanwhile, our single entry points provide services to people with physical disabilities. Then on the far right, we have our area agencies on aging. As again, you may know, they provide services to those individuals who are 60 and older. Don't necessarily focus on individuals seeking Medicaid or who have Medicaid. And then at the very top, we have our aging and disability resource centers, who provide services to adults with disabilities and also to our elderly population. And they do provide some Medicaid services. However, they're currently not receiving payment for those services, but the department is actually working on an effort currently to try to help them obtain a federal match for those Medicaid related services. And then last but not least, I want to highlight on the far right top corner is our Department of Human Services, our County Department of Human Services, that is, and they provide a lot of similar functions that the rest of the other agencies provide, in addition to doing the financial eligibility determination process for long-term care Medicaid. And just to really briefly let you know, I will be stopping mid-presentation for any questions, but feel free to ask any questions throughout. So what I wanted to, again, because you couldn't read it, I wanted to really demonstrate throughout this puzzle the complex system that our people with disabilities populations and our elderly populations have to try to navigate in order to try to access long-term services and supports. And so it's a very complex system that we are trying to streamline. So what is No Wrong Door? No Wrong Door is a seamless entry point system for all individuals, regardless of age, disability, or pay source, to access long-term services and supports. And the pay source part of that is extremely important because, again, like what I mentioned during the long-term services and support puzzle, there are some agencies that provide services to individuals with Medicaid, and there are some that don't. So with our growing demand for long-term services supports, we need to make sure that we are able to provide services to everyone regardless of their pay source. Okay, so to provide you a little bit of background, Gretchen touched on this earlier, and so in 2012, Governor Hickenlooper issued an executive order calling for the creation of the Office of Community Living and also the creation of the Community Living Advisory Group, also known as CLAG. And CLAG was tasked with looking at different ways for individuals to remain in their community as long as they have that chance to do so, and as long as they're receiving those supports and services that they need to live in that community. And so I want to bring to light that this is actually a part of a broader effort that's actually happening across the country. So what we're seeing is that state and federal governments are trying to prepare long-term services support systems to be more user-friendly, as demonstrated by our current status quo. It's not user-friendly. It's a complex system, and also to be more responsive to the growing demand for long-term services support. So, as you may or may not know, in Colorado alone, we have our aging population doubling in the next 20 years. So from our current status quo of 700,000 to 1.5 million in the next by 2040 of elderly population, and just in general, people are living longer. So are people with disabilities. So we need to take all of that into account. And what we're looking at is that across the country, again, it's a trend that our long-term services support systems are not streamlined, and so everyone's trying to prepare for that doubling of the aging population. And so what the CLAG ended up coming out as a recommendation is to create a comprehensive access points for all long-term services supports. Can you click on it? Yeah. No. Okay, so the next initiative that I want to talk about happened shortly after the CLAG recommendations happened. So the CCLP is actually the Colorado Community Living Plan, and that was actually Colorado's response to the 1999 Supreme Court Olmstead decision, which states that individuals have the right to remain in their community and should not necessarily be placed in facilities such as skilled nursing facilities if their conditions don't necessarily call for that. And so around the same time, George Bush issued an executive order stating that states are required to try to help individuals live in their community as long as they choose. And so with all of that being said, some of the CCLP recommendations call for helping individuals transition from skilled nursing facilities to home and community-based services, and then also helping individuals with the diversion, well, also developing ways to divert individuals from going straight to a skilled nursing facility and maybe giving them their options to home and community-based services. And as well, again, because of the long-term services support puzzle, and similar to what the CLAG was doing, it called for the improvement of communication across agencies to help improve the accuracy. Improve the accuracy and timeliness of the services provided.
Give him the, he'll take that off your hand so you can move through it and the slides will go.
Okay, thank you. And services options in Colorado. Next slide. So the background again, those are the two main initiatives that we took into account in order to develop this no wrong door concept. So then in September of 2014, we applied for a grant from the Administration for Community Living, which is actually a branch of the United States Department of Human Services. And it was a one-year grant in order for us to develop a 3-year no wrong door implementation plan to help streamline the way individuals access long-term services and supports. Then after we received that grant, we collected about 45 different individuals representing entry point agencies, representing the regional care collaborative organizations, individuals who are seeking services, caregivers, hospital discharge planners, and all of the entry point agencies essentially were involved in those conversations. And so they met 4 times in the spring of 2015. And during those conversations, they ended up developing what is going to be in that 3-year no wrong door implementation plan. So everyone's input was taken into account in that development. Then for something that more recently happened in July of 2015, we applied for another grant from the Administration for Community Living, requesting that they support our implementation of the 3-year implementation plan. And then in September, we've received those funding. And then I think shortly thereafter, we hired our project manager, Aaron Snyder, to start doing the work. No, you're fine. Thank you. Okay, so I want to go over the No Wrong Door mission. So the No Wrong Door mission is talking about Colorado's No Wrong Door system through collaborative partnerships, increased communication, and shared technology. Ensure that all Coloradoans with disabilities and older adults are connected to the supports and services they need to live dignified and self-determined lives in the community of their choice, regardless of pay source. So again, as what I demonstrated in the long-term services support puzzle earlier, these agencies are frequently not communicating with each other and streamlining services. So they'll refer individuals to another agency, and we'll hear as concerns from the individuals seeking services is they're constantly having to retell their story. And these agencies on top of that are duplicating their services more often than not. So this is what No Wrong Door is aiming to affect. And as a No Wrong Door vision, our No Wrong Door vision is for Coloradoans with disabilities and older adults to easily obtain comprehensive information and streamlined access to personalized services and supports that promote dignity, respect, and freedom of choice from wherever they enter the system and as for as long as they need services through the system. So the 6 criteria for a fully functioning No Wrong Door system is we adopted this from the Administration for Community Living. So they gave us 6 criteria, which I will go over. The first one being information, referral, and community awareness. So information and referral is about standardizing the referral protocol process to make sure that we're all on the same page as to how we're referring individuals across each other to make it more streamlined. And the community awareness part is about improving our marketing strategy so that people are aware of the No Wrong Door efforts and are able to access this No Wrong Door system.
Excuse me, Madam Chair. And I saw area agency on aging in an earlier slide. Is that where the rural communities are being served, is through area agency on aging? Is that where folks, seniors go to find out what's available and what you're talking about here then?
Well, we have, AAAs and ADRCs, the Aging Disability Resource Centers, are where our elderly are predominantly going.
What was the
If they know about it.
If they know
about
it, that's a good point.
Or if they're elders and have disabilities, they may go to the community center board. But that first slide that looked like a spaghetti bowl with arrows, that is how families feel, is they don't know where to go or who to call. And oftentimes they call the wrong place and are referred. So this is one place, a kind of a one, you know where to go, rather than your seniors or your people with disabilities not knowing who to call. And so that's the whole intent of this.
And this is Dr. Liplis. I just want to add to that it's not just the clients who don't know, it's the providers who don't know.
Good point.
So this is I'm hoping and I'm sure to also educate the actual service providers who's doing what, how they do it, and allow them to communicate with one another. Because as a physician, I know that communication is poor at best amongst providers and agencies. You focus on the individual patients you're taking care of, and how accessing services can be extremely confusing to the people who are trying to help you access those services. So I'm happy to see that this communication, not just for the clients themselves, but for the providers who they'd be asking the questions to.
Right. And Donna, it's David, did you have a rebuttal or response?
Another question.
Okay.
Then are you going to get to your marketing plan in your presentation?
I can touch on that a little bit.
Okay, that'd be helpful. Because
okay.
Just a tiny bit though.
How your folks will, and then you
how rural Colorado.
And Chris can connect you with Ruby afterwards to get.
Well, I'm not worried about me.
Okay.
I'm worried about
your community.
Rural,
I know, but
all rural Colorado.
Right.
Okay.
Good point.
Great.
Ms. Roberts.
Thank you, Madam Chair. To David's point, in our rural 6 county areas that I represent, we have local ombudsmen in each county, or someone that serves more than one county sometimes. But those individuals oftentimes go to meet and talk with seniors that are engaged. Again, there are a lot of unintended consequences because there are people that do not make it in from the outer areas of rural America into a meet location or such like. But they'll distribute things to churches and things like that to help educate them as well as to what the aspects are.
Not seen any of this other than through AAA.
Okay, all right. Okay, thank
Okay,
you.
Great, thanks. So the second criteria for a fully functioning no wrong door system is person-centered options counseling. So this is really the heart of our whole no wrong door system. We want to make sure that we're putting the people with disabilities and our elderly populations in the driver's seat and making sure that we're giving them comprehensive information, such as what the CLAG recommendation calls for, comprehensive entry point access services. And so we want to make sure that they're fully informed about all of their options and that they are able to make informed decisions on the long-term service support and long-term services and supports that they wish to acquire. Then we also have streamlined eligibility. So as you may know, there's that functional eligibility determination and that financial eligibility determination in order to obtain long-term Medicaid services. And so currently, as I demonstrated earlier in the long-term services support puzzle, we have our case management agencies, our community center boards on single entry points doing that functional eligibility determination. Meanwhile, we have the county human services offices who are doing that financial eligibility determination. And we frequently hear concerns from all agencies and the individual seeking services that they're constantly having to wait on each other to provide that functional eligibility determination or providing that financial eligibility determination in order to move that person forward towards determining their total eligibility process. And so that frequently causes delays in individuals being able to get those services. And then we have person-centered transition support. So again, because of the Olmsted decision and our Colorado's response to that, the CCLP was wanting us to really help individuals transition not only from skilled nursing facilities to from one care setting to another, so skilled nursing facilities to a home and community-based service setting as an example, but also maybe from one program to another, and even from one life stage to another. So for example, our children with disabilities growing up to be adults with disabilities. So we want to make sure our no wrong door system provides that service as well. And so we also have consumer population and stakeholder engagement. So again, how we emphasize the priority of making sure that the individual seeking services is a part of that conversation. During the development of our 3-year implementation plan, we made sure to include them, include all stakeholders, so all entry point agencies involved, have them all involved in that conversation because this no wrong door system has implications for the way that they're going to be providing services. And the last one is quality improvement and quality assurance and continuous improvement. So for the quality assurance, that's where our data collection comes in. So I'll get to that more in depth in later slides, but we will be evaluating this no wrong door system because we want to make sure that it's truly doing what we intend it to do. And so if not, if for whatever reason we go off the wrong path, we are going to be continually improving it to make sure that it does do what we want it to do. So we have a vision of what our no wrong door system will look like, and this is what it will look like on the local level. So we will have no wrong door regional entities across the state. So we currently don't know how many regions we will have or where they will be located, but our vision is that we will have a lead agency in each region coordinating all the other agencies to make sure that we complete the 6 functions of a fully functioning no wrong door system, and that we're coordinating, improving communication in order to get that person access to all the services that they want and they need. And so you may be asking yourself, well, doesn't no wrong door mean that any door is the right door already? Well, again, as demonstrated in our status quo long-term services and support puzzle, we have various agencies providing services to different populations and to different individuals based off of their pay source. They're providing different functions. So it's not currently a no wrong door system. So again, this is why I'm talking to you today, because there's possible policy and regulation implications in the future. So our no wrong door system will make sure that these no wrong door entities have person-centered options counselors as well as person-centered transition support. Lastly, in developing these no wrong door regional entities, we will also have regional advisory groups and again regional referral sources and community organizations who will help implement that marketing and public relations strategy as well. So in order to oversee, or in order to make sure that these regional entry points are across the state, we also have the state level oversight that's going to happen. So of course, what we talked about earlier in these and the CLAG and the CCLP is that these were executive orders coming from the governor's office. And then we'll have state executive level decision makers. So in this No Wrong Door effort, we actually have the involvement from not only the Department of Healthcare Policy and Financing, but we also have involvement from the Department of the Colorado Department of Human Services, which oversees the AAAs and the ADRCs, and as well as the Department of Colorado Labor and Employment, Division of Vocational Rehabilitation, that oversees the Centers of Independent Living. So we have the 3 state agencies that oversee the agencies that I highlighted in the long-term services support puzzle, making those executive decisions, the bigger decisions related to No Wrong Door. And then we will also have a state management level that will be able to make decisions on the day-to-day functions of the No Wrong Door system. And so these 3 things will have our state level oversight. These 3 groups will have our state level oversight. So as you can see demonstrated, they will be doing they were overseeing all the regional No Wrong Door entities. And so because, again, No Wrong Door's mission is to provide services to all individuals regardless of age, disability, or pay source, we do anticipate in the near future doing private and public partnerships and developing a board to make sure, again, that those comprehensive access points are comprehensive in providing services, again, to everyone. And because of that quality assurance that we're aiming to achieve with No Wrong Door, we also hope to work with our community access ombudsman to solve any complaints that we may have. So if any individual accessing this No Wrong Door system is unhappy, they will resolve those complaints. So the last thing I want to highlight overall is that we also want to develop some state shared infrastructures. So that will look like a statewide database, as an example. As you may or may not already know, we have all of these different agencies working in about 4 or 5 different databases each. And regardless if you're the same if you're a AAA in Denver, as an example, or if you're a AAA in Southwest Colorado, regardless if you're both a AAA, you can be working in different databases. And even if you're in the same database, you have different contracts with different contracts with the same vendor maybe for the database, but you can't communicate via your system. So we're hoping to streamline our database with the state shared infrastructure. And then we also want to do a database website, sorry. Oh, you can just do them all. There. Okay. So we also want to develop a No Wrong Door 1-800 number, No Wrong Door website, and a franchise model, because what I showed you in the review of what we envision our No Wrong Door to look like at the local level, that's actually going to be a behind the scenes situation. So we envision it being a franchise model. So as an example, you may go to a McDonald's or Starbucks. Whichever McDonald's or Starbucks you go to across the state or even across the country, you receive the exact same experience wherever you go. So we hope that we develop a No Wrong Door system that regardless of the door that the person enters, they again receive that exact same experience regardless of they go. And currently they don't receive that. It's varied based off of level of experience, the information that is accessible about programs and services available in their area ranges. And what the agency currently has. So more recent developments is what we have is in November 2016, we posted our request for proposal to have agencies submit their proposal to be a No Wrong Door entity during a pilot period of testing that model. And in March 2017, we had our No Wrong Door pilot sites selected. So we had 4 regional pilot sites, which I will go into more depth in a little bit of what they're doing in a short period. And then from March to July, we were developing those contracts and finally launched all 4 sites come July and August of 2017. And starting in October, we started October of 2017, we started actually piloting our No Wrong Door regional model, which called for the creation of each No Wrong Door each No Wrong Door entity that's piloting this model that I demonstrated to you is required to develop a startup plan, a business continuity plan, a marketing strategy plan, and develop a lot of other things so that we can make sure that have, again, all those 6 criteria be demonstrated during the pilot period. So this is where I'm going to stop for a moment to ask if there's any questions, and then if not, I'll move forward in describing the rest of the pilot sites.
Dr. Lipolis?
So my question is, if the pilots are ending in 2019, what's your vision for statewide adoption?
Yeah, so I will actually be going into that in the second half.
Right.
But yeah, okay.
All right. Any other questions? Okay, move on.
Great. Thank you. So I'm showing here, what I'm showing here is a map of Colorado. As you may already know, it's square and in the middle of the station. And to start off with, because we're in Denver right now, I'll highlight our No Wrong Door metro area in green. You go back. Sorry. I'm just going to in general show that we have these are the 4 regions. We have the No Wrong Door metro in green. We have Larimer County in red, Pueblo County in blue, and then Southwest Colorado's No Wrong Door pilot, which is our rural pilot. And I will go into more depth in the next few slides. So to start off with the No Wrong Door Metro pilot, that's composed of 4 different counties. So we have Denver, Adams, Arapahoe, and Douglas as part of that No Wrong Door pilot. And the pilot lead is actually our single entry point agency, Colorado Access. And the person who's leading the effort is going to be Laura Martinez. And so what they're focusing on is having a telephone staff with person-centered options counselors to make sure, again, people are provided that comprehensive information in order to gain access to services. And additionally, they'll be supporting all the agencies in the pilot by developing a shared case management system that they could all use, maintain, and share information about individuals that they're referring between the different agencies, again, as long as the individual consents to that being shared and wants that to be shared. So they'll specifically using a database called Altruista to do that. And then lastly, they came up with a very unique strategy as well, is that they have developed a person-centered traveling team. So the individuals who are in the traveling team are actually individuals from each agency. So they're all representing their agency in this traveling team. So they'll be traveling across the different agencies in the region to help people get connected more easily. So next I'll be going over Larimer County No Wrong Door. So Larimer County, the agency lead is Larimer County Department of Human Services. The project lead is Kelly Morrison, the Deputy Division Manager. And what they're focusing on is creating a new person-centered options counselor. Again, they realize that they need to focus more on emphasizing the importance of long-term care because, again, they are the Department of Human Services. And they'll also be improving the way that they refer individuals, again, across their agencies by developing a new regional tool, a new regional intake tool that takes into account all of the type of questions that all of the agencies ask when they're doing an intake for them, so that they can use that across all the agencies in the pilot and get the person access to their services more easily. And then, so lastly, with all of this, they will be acting as a link to people get connected to all those services and supports via the use of this regional tool and via increased communication that they're more purposefully doing during the pilot period. Then we have Pueblo County No Wrong Door. The lead agency for this No Wrong Door pilot site is the Senior Resource Development Agency, which is our aging and disability resources for Colorado in that area. And the project lead will be Tara Morrow, who's the ADRC and 211 supervisor. And what they're focusing on is using an existing call center that they're going to be enhancing with text and chat features because they understand that individuals try to access these services via different means of communication. So they'll be enhancing their call center to have that additional feature. And then they'll also be restructuring their current database in order to, again, improve the accuracy of the information that they're providing to the individuals walking through their door, and also make sure that that information is very comprehensive. They're also going to be emphasizing the importance of the quality assurance. They'll be working with their ombudsman's program to make sure that everybody is satisfied with the services that they're receiving, and if not, try to figure out how to make them more satisfied. And the last thing that I want to talk about is them developing partnerships, getting more with each other, more purposely with each other, because they really want to make sure to make comprehensive public and private resources more available to those individuals seeking services. Last but not least, we have Southwest Colorado's No Wrong Door, which actually is the biggest of all of the 4 No Wrong Door pilot sites. And so that's comprised of 5 different counties. We have Dolores, San Juan, Montezuma, La Plata, and Archuleta counties. And the project lead, or the agency lead, is actually going to be our San Juan Basin Area Agency on Aging. And the project lead is going to be Christina Knoll, who's the AAA director in that area. So what they'll be working on is, because again, they're the rural pilot of all of these, they haven't had access to a lot of the things that, you know, some of our bigger counties had access to. So for example, Network of Care is something that has that's been in Denver Metro for a very long time, Boulder for a very long time, but they've never had that. So they're really going to push to develop a centralized hub for all of the agencies involved in their pilot to really be able to use and communicate across them more efficiently, so make sure that person's connected more easily. They'll also be improving their the processes by which they provide person-centered options counseling and refer individuals as well. So they'll be improving their processes to make sure that that is enhanced. And lastly, again, in every way, shape, or form, they will make sure to have the person-centered options counseling happen. Make sure that person's in that driver's seat so that they can make those decisions, make informed decisions based off of everything that we are able to provide, because the centralized hub will make sure that all the agencies are on the same playing field, have access to all the exact same resources. So regardless of which door that person enters through, they will be receiving that same information. Same comprehensive information. So this is where I'm getting to the toolkits and so the pilot deliverables and the long-term strategy of what's going to happen as a result of the pilot period. So the first thing that's going to happen is the first deliverable is we're going to develop a toolkit. And within this toolkit, we will have a series of job descriptions that we're going to be looking at developing again during the pilot period of what individuals need to be doing in order to really be performing the 6 functions of a fully functioning No Wrong Door system and providing services to everyone regardless of age, disability, or pay source. So we'll develop those job descriptions during the pilot period. We'll also be providing or developing decision support tools. So these decision support tools again are for that franchise model concept. So again, regardless of where you enter across the state to try to access services and support to receive the same experience. And then lastly, within this toolkit, we'll be developing operational protocols, processes. So again, having that franchise model of how do you function to make sure the individuals receive the same experience, that they're not constantly having to retell their stories, and that agencies aren't duplicating services. The next, or the last pilot deliverable that I want to talk about is some action plans. So the 2 access plans, the first one is the regulatory and policy barrier action plan. So that's where you come in, right? So again, because our LTSS puzzle currently is very complex, agencies are not coordinating with each other, not communicating with each other. That has a lot to do with current policies in place that silo them based off of funding source, that silo them based off of the individuals that they're allowed to serve because of policy regulation, and that silo them because just because in general the these policies don't help them or support them or encourage them to work with each other more collaboratively. We've done an initial assessment of policy regulations that guide all of these agencies that I highlighted in the long-term service and support puzzle, and there's very little, if not any, supportive language to encourage them to work together. Okay, and the next action plan we will be looking at is developing a financial model. So again, because No Wrong Door is about providing services to everyone regardless of age, disability, and pay source, and our agencies currently don't do that, not only because of policy, but because of funding. Funding limits them. So we need to develop a financial model that not only helps them provide services to people who have Medicaid or can obtain Medicaid via the Medicaid Administrative Claiming federal match, but also we have to take into account that a lot of the population will be private pay source individuals, and so we have to figure out a way to support all of these long-term service support agencies to provide services, again, regardless of age, disability, or pay source. And this is the last slide, and I'll go more into depth into the two questions that I got about marketing and the long-term strategy after this. But for the data collection strategy, we want to make sure that we are actually getting what we want to get during this pilot period. So we're working with the Center of Network Science at the University of Colorado, Denver, who's actually going to be administering 4 different types of surveys throughout the pilot period in order to make sure that this No Wrong Door pilot is actually doing what we set out to do as far as streamlining access to services, getting people connected more easily, and then helping us develop those action plans for the regulatory policy barriers and that financial information. So this first survey is about doing a scaled down time study of the agencies participating in the No Wrong Door pilot to determine what percentage of the time they're doing different activities. And there's a supplemental part of that survey which determines the administrative costs that they're taking on in order to provide services, again, to everyone, regardless of age, disability, or pay source. The second survey is going to be a survey of the frontline staff because, again, if we change any public policies or regulations, that's going to affect them and the way that they provide services. So we want to make sure that they're happy and get their input as to what we should do to continually improve. The next one is the referring agency survey. So you may or may not have experienced this ever of being a part of an agency and you refer someone to another agency and you never know what ended up happening with that referral. Did they truly get connected? How quickly did they get connected? What was the quality of the services they received? Did they ever fall through the cracks and were not informed of everything that they possibly were eligible for? So we will be surveying our referring agencies. So every agency who refers to a No Wrong Door pilot agency will receive a survey in order to gauge their experience of how well that's working, if anything is different, how can we improve. And the last survey that we're talking about is not last but not least is one of the most important surveys, which is our understanding the individual who's seeking long-term services support, their perspective, as well as their caregiver, their proxy, to make sure that we have that full perspective of what is this experience actually like for them, and is this different from the current LTSS puzzle? Are we truly streamlining everything? So that's the last slide, but I want to touch on, I went through it very quickly, and I want to touch on the 2 questions that were asked by David and Charlotte. Is it Charlotte? Okay, great. So starting with David again, because in our contracts that we have with the pilot leads, because we have lead agencies in every region, we have them, we're asking them to develop a marketing strategy to help people be more aware of their No Wrong Door system during the pilot period. So we actually have a contractor, Nonprofit Impact, Karen Buck specifically, who is working on the front lines, who's constantly talking to all of our pilot leads, the agencies involved in the pilot, and talking to them about their marketing strategies. So they've all developed slightly different marketing strategies. For example, No Wrong Door Metro has strongly utilized social media in order to communicate information about their No Wrong Door system. So please be advised, we have a 1-800 number. Please call us for person-centered counseling. That kind of message is being sent. They did develop flyers, but they found that they weren't as useful as they hoped that they would be because they were too big. So they actually ended up also developing business cards so that people can easily carry those in their wallet and remember, oh, I can talk to this person. I could call this person. So they're using a lot of different efforts there. So all of the pilots, excuse me. All of the pilots are doing something differently. But again, we're supporting them in developing that marketing strategy and implementing that marketing strategy during the No Longer pilot period. And we hope to, again, further develop that marketing and public relations strategy during statewide implementation. So to Charlotte's question of what is this all going to look like after the pilot period? Well, again, with the development of those action plans, we hope to be more prepared in implementing the statewide. But the pilot period is really here to, again, test the model, identify best practices, implement all the CLAG and CLIP recommendations. So we hope to be prepared to sorry, my throat just died. We hope to make sure to be prepared after the pilot period.
Dribble that. Thank you very much.
And
Does
I guess-
anybody, Charlie, Dr. Liblist?
Yeah, and I guess just more specifically, is there like a 2025 will be statewide? Is there like a target statewide date? Because I know implementation takes approximately forever.
It does.
So I'm curious what the potential end date goal might be for statewide, knowing that after piloting, then you have to analyze the data and look at the packets and let another year of probably developing the toolkits appropriately. So just wondering what the goal statewide date might be at this point.
Yeah, that's a great question. And actually, this week, we're actually going to get together to update our 3-year implementation plan to make that determination. But during the pilot period, what we're finding is that we really needed to define what partnership meant between the state agencies and the local agencies. So this partnership is not only about getting information from them, but it's about how do we support each other? Because we have a mutual interest of helping this population or these populations. So how can we do that together? And so yes, the department could probably say we're going to implement this by 2025 as an example, but it really needs to be there needs to be buy-in at the local level about this may be affecting your job position based off of rules and regulations that are updated in order to streamline services. Maybe for the Conflict Creek case management issue, for example, we might be moving information and referral. We might be moving the functional eligibility determination service from the case management agencies, the CCBs and the single entry points, to maybe another to the No Wrong Door agency. Meanwhile, they are able to keep the case management services, which is after the entry point service. So I think that we're going to determine that during the pilot period. I think one of the biggest things that we're focused on during the pilot period is not only making sure that these agencies are partnering with each other and improving their collaboration around each other, but that at a state level, we're partnering with our local level and we're coming to that unified agreement as this is our mutual interest and this is how we get there. And hopefully they'll be okay with those, again, policy and regulation implications that will affect their work.
Thank you very much. We need to move on.
Okay.
As we have 2 previews for rules for next month, and this group, we're getting past time. So, thank you.
Thanks, Ruby.
Her contact and Erin's contact are on there, so if you have any questions, you can reach out to them. Yes, Erin Thatcher, come on down. It's in-home support services, which is another one of those long-term care, blah, 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 blah.
Good morning.
Okay, good morning.
How is everybody?
Good.
Good.
We're getting weary of, so
I'll be quick.
your expedition will be appreciated.
Thank you. So I'm Erin Thatcher. I'm the Participant Directed Programs Liaison for the department, and I work with In-Home Support Services, and that's also known as IHSS. IHSS is a participant-directed program that allows people more flexibility and control in managing their in-home services. It's available in the adults waivers for elderly, blind, and disabled, and also spinal cord injury, and then also for children under HCBS, children's HCBS. The great thing about IHSS is that we work with agencies to provide additional backup. So the client can direct their care and then have the agency to support them with 24-hour backup services, nursing oversight, and then independent living skills training. In 2014, legislation was passed to increase the family member maximum for for personal care. And we put that into rule change. And following that legislation, there was so much interest in IHSS from the provider standpoint and also from clients and family members who wanted to exercise this option. And we pretty quickly realized that we were missing a lot of content in our rules and some definitions. And so about 14 months ago, we started working with a work group of stakeholders and clients and authorized representatives, case managers to develop better rules. And so we've done that. We're really excited to share that with you next month. A couple of the key concepts are new definitions that we worked really closely with our stakeholder groups and the health department to create. And additionally, looking at content and the roles and responsibilities. Who does what, who's responsible for this, and who has the oversight and responsibilities in IHSS. So we do have a couple of outstanding issues, just to put them out there. One of the concepts in IHSS is if you need an authorized representative, your physician would indicate if you needed help to administer the program. And so we had put in a couple of new criteria for the authorized representative, which would better support program development and implementation and make sure that things are being done appropriately. We did have some stakeholder feedback that they weren't really okay with that. We have come up with a couple of workarounds to make sure that our stakeholders are being heard and also our clients are being represented well. One example we run into with IHSS is that we'll have a family move here from another state. It'd be a single mom with a child on CHCBS, and the child needs services, and the mom's going to be the primary caregiver. So they don't have an authorized representative available to be that person. So a lot of times we'll have the agency provide additional support and maybe hiring a backup caregiver. And we have put in some controls into the rules to help manage and make sure we're mediating any conflict of interest. But we do have a little bit of a bone of contention there. But I'm excited to bring it to you next month. And if you have any questions, I'll hear them now or next month.
Any questions?
Okay.
Just one small background. Okay. In-home support services is one way of delivery system for in-home or home health care. So that gives you a little bit of a bubble around where this sits and what it talks about.
And it's not an individual, Brigida Hughes, it's not an individual waiver, however, right?
It's not an individual waiver. It's a service delivery plan in some of our waivers as a way to deliver home health care.
Okay.
Yes. Okay. So is that clearer?
Yeah.
Clear as mud. Okay. No, thank you so much. And we'll look forward to it, but we'll watch for those criteria, AR criteria. Richard Clark, going to give us a little bit of a preview on nursing facility post-eligibility treatment of income. Is there an acronym for that?
Yeah, there is. It's
goody.
PETI PETI. We call it the
good.
PETI programs. So I'm Richard Clark. I oversee the benefit policy for our long-term care institutions. Specifically, that's going to be our nursing facilities and our ICFs, our intermediate care facilities within the state. The rule that we're proposing next month has to do with the nursing facility post-eligibility treatment of income, the PETIs for short. This is a broader area of rule that deals with an individual needs to allocate their income towards once they're already eligible in a nursing facility. They have to contribute a substantial portion of their income each month to offset their costs when they're in a nursing facility. We'll make certain adjustments towards that, their share of the costs, depending on their individual situation. The specific portion that we'll be looking at in this rule is about incurred medical expenses that that person might come across that is not covered by the Medicaid state plan or the nursing facility benefit. An example of this would be hearing aids. It's not in our Medicaid state plan, it's not in the nursing facility benefit. So if they need those hearing aids, we'll essentially adjust their income to allow them to purchase those items. The rule revision, it's somewhat of a section revision, but it's generally going to be a maintenance on this this area of rule that's just kind of updating to accommodate for a lot of the things that's happened since the last time it was touched. We've had a dental benefit change in the state plan. Recently, there was a vision services change in the state plan. So this is going to be clarifying how those interact with each other, what we'll pay and when we'll pay it for the nursing facility petties. And then additionally, there was just some cleanup of some regulations that no longer are valid. We've had some system solutions, so we were able to remove some pieces. And then we added a timely filing waiver or time frame on this so that we're not receiving claims from 5 or 6 years ago, that we're standardizing that with the rest of the Medicaid benefit. But a lot of that's just going to be in the presented in the context of what a nursing facility or an individual needs to do to have their income adjusted and allow them to pay for services. That's what that'll look like, and I'll obviously be around next month to speak on it a little bit more.
Any questions for Mr. Clark? Okie doke, we'll look
All
forward
right.
to hearing,
Thank
seeing you
you.
again and hearing your rule. Okay, with that, we may adjourn. So tell us where we're supposed to be regrouping.
Okay, so we're gonna be down at 1570 in the main Hickbuck building on the first floor, but I'll just meet y'all down there in the lobby. And
By
we'll
the
be-
elevators.
Yeah.
Just around that corner, okay.
Right. Yeah, you're gonna walk.
Is
in the door
everyone
and you'll
joining
be
us or
right
is there somebody exiting? David, you're exiting?
Child welfare this afternoon.
Understood. Donna,
we
you're
doing?
leaving? Okay.
there. Hospital payment reform.
It's just a presentation.
It's a presentation and lunch.
It was a little bit of a follow-up from the providers' concerns that we heard in Salida.
So we're
we'll
sorry
make
you're
sure
not
you
gonna-
get the presentation
Yeah,
for
we're
sure.
sorry you're not going to
Will.
join us, but
Yeah.
Okay.